Kia ora koutou. Welcome again to one of Mobile Health's lunchtime webinars. I'm Pauline. I work with Mobile Health in the Rural Health Professional Development Program, and it's my pleasure today to introduce your speaker. We have Anne Caldwell, who's a cardiac rehabilitation nurse specialist and cardiothoracic surgery coordinator based at Christchurch Hospital. And Anne has a dual but integrated role of cardiac rehabilitation, nurse specialist and cardiothoracic surgery coordinator. The surgery coordination aspect begins at referral and continues through surgery workup, managing the patient during the wait for surgery and contributing to the compiling of the theatre list. Cardiac surgery rehabilitation role involves patient preparation, education, pre and post-op, following up after discharge into the community, and being a resource person for patients and families throughout their journey. Anne's Masters Dissertation involved auditing patient experience after cardiac surgery, and the audit tool remains live and the data informs this presentation. She will be summarising the issues and the complications that patients experience, and the topics include overview of patient education, pre and post-op, support following surgery, and the complications and issues experienced at home. Now, so welcome again, and thank you, Anne, for joining us today.
Thank you. Hi, everyone. Thank you for coming and spending the time. So I've worked in heart surgery for over 20 years, but in different roles. And today is about helping people in the community understand a patient's journey and what they go through. And what I'm going to teach you is actually what patients have taught me. So we'll start with pre-op education, pre-op and post-op education resources. I'll talk about the community and what happens there, what follow-up we give the patients, talk about the patient's perspective, home alone after surgery, complications and issues at home. So I just want to tell you a wee bit about my role. So I work with the 3 heart-lung surgeons at Christchurch Hospital, and I'm involved with the coordination of the surgery list, which can change every day, sometimes several times. So we're managing, me and my colleague Vicky Ray are managing people off our waiting lists, emergency surgeries, people who are waiting at home or people in the hospital. And also my passion is the cardiac rehab. So I get I follow up people I meet people before surgery, follow them up in hospital and have the privilege of following them up at home. That's my role. So I wanted to talk first about the education. So we'll start there. So pre-op education, what I did when I first started is I audited patients of what they wanted to know before surgery. And it's quite funny because a lot of them will tell you they don't want to know anything. So basically, I teach them what they have said that they want to know. So the 2 heart surgeries we do really is valve surgery. So valve surgery can be a mechanical or a tissue valve in the aortic, or in the mitral position, or in the tricuspid position. So whatever is wrong with the patient. We can do double valves. Most mitral valves, the surgeons try to repair, so they repair with a ring. And we also do bypass surgery, which I tell patients is building bridges over your blockages using your own veins and arteries. So these are the 2 surgeries we do, but we do big aortic surgeries as well. And of course, we do lung surgery as well and address traumas, fractured ribs. But for this talk, I'll focus on heart surgery. So each patient gets a booklet explaining the journey right from the beginning, right through to surgery and recovery. And what I've done is made it so there's everything in that booklet. And what I do is I do education sessions before surgery and I include the relatives. There is no point educating someone without their relatives. And quite often you'll get a patient saying, oh, no, I don't want to bother my wife. And this is huge open heart surgery with a risk to it. So it's really important to involve the relatives. I have to say, having heart surgery would be one of the scariest things I feel people could ever have. And it would be like if I said to you, you're going to have heart surgery next week, because a lot of these patients don't know that they even had a heart problem, let alone coming in and then being told that they can't have a stent or their valve has to be taken out and a new one. And so this is a very upsetting and vulnerable time for patients. And quite often when I meet people, they're upset, they're worried, they're petrified. I've got a lady at the moment who's terrified. So this is just a huge endeavour for anyone. And patients will tell me after their surgery that this was a life-changing experience and the most scariest they've ever had. With families, sometimes with family fallouts that have happened previous to surgery, or patients with family overseas, this can be really a very hard time, and it certainly was through COVID. So I can't, from working in heart surgery for 20 years, my biggest thing is being compassionate and supportive and being there for people, because this is very scary for them. So you can see that I do education sessions. So I go to attend a cath meeting on a Tuesday where patients are discussed with the surgeons and the cardiologists, working out the best treatment for these patients, whether they need to stay in hospital or whether they can actually be discharged home and have surgery as an outpatient. So you'll see that I do 1 o'clock sessions, I call it, and sometimes I've had 18 or 20 people in those sessions. And quite often it's really nice because people talk to each other and they get to know each other, and sometimes you get patients actually competing against each other after surgery who can do better. So the research actually showed before my Masters that you're better to do individual sessions, but patients have told me since that they like the group education sessions to meet people, to feel like they're not the only one. And of course, after the session, if people have got intimate questions they want to ask or individual questions, of course, I answer them as well. Now, this is, you'll see after heart surgery information sessions. So yes, if a patient tells you they didn't get information or education after surgery, they certainly did. Because patients forget after surgery. I say the cards have been a bit shuffled and it takes a while to get them in the right order. So this is why we do not do education without their relatives, and everything I say is in written form. So if you're a district nurse looking after a heart surgery patient, of course, you can go to their booklets, all the information's in there for you to read, and that's a resource for you as well. Now, this is a picture of the heart surgery, so you can imagine, and this is Eric, and I just wanted to talk about heart surgery and how quick it is. So this is Eric, and he's had heart surgery. So he wanted us to take photos to show patients. He signed a consent, of course, that everyone can see him. So he's had bypass surgery. So his operation was 4 hours long. Then he moved to the intensive care unit. And then 7 hours after intensive care, his tube was taken out, and so he could talk, eat and drink. And this is him the next day sitting in a chair, playing on the computer, and this is him up, moving after his surgery. This is the next day after. Most patients all doing well. If their recovery is straightforward, they will go home day 5, day 6. We've had some patients go home day 3 after surgery. Some patients are in 10 days, 14 days. You never know meeting someone how long it's going to take them, because it depends if their body behaves or not. But, the problem for me is sometimes patients go home. So to go home after heart surgery, you've got to be able to shower yourself. You've got to be able to do 2 flights of stairs. You've got to be able to get in and out of bed yourself. You've got to be able to dress yourself. We do an X-ray, so we know if patients been walking, because we know if their lungs are expanded or not. And, they're told not to do any heavy lifting, of course, for 3 months. But you will, sometimes they go home to the community and people are saying to them, oh, no, you shouldn't be showering yourself, or you shouldn't be doing this. And that's the worst thing we want after heart surgery. We want them to be getting back into life. No heavy pulling and pushing on that chest, but of course we want them showering every day. We want them walking outside, going for walks. So it's about walking and resting. So I will go over and spend a bit of time with you going over this now. So what I did from my Masters in Nursing is I had a database, and I actually made it myself with a computer expert at the hospital. And what I started doing is I started getting categories of all the problems patients told me they experienced at home. And then I started grouping them together. And then I realised that this is what they were all saying that they go through when they go home. So what I do is before they go home, I educate them on everything that could happen at home and what to do if it does. And so the biggest complication I know is fluid in their lungs and pleural effusions, and how patients will know as they get short of breath doing nothing. So it's important, and I'm going to go over all the complications later, but I wanted to explain where I got this information from was from the patients. So 4 or 5 days they're going home, and we'll talk about the care that we give them. So they have the education with me or another nurse. We go over all the complications they can experience with their relatives in a group session. Then they're discharged from hospital, and we have the district nurses from Healthcare NZ going in Christchurch, and we also phone them the next day. So one of the team, either me or one of my other colleagues, we ring them to see if they're okay. So this is day 1, day 2 after surgery. We also want them to go to their GP that first week, and that's what the surgeons would like. And if they're on warfarin, we want them to go the next day to say, hey, I've got a mechanical valve. How am I going to do this warfarin? My INR needs to be between 2 and 3. So, what's the best way for us to do this? So there's my card. So the surgeons know that everyone gets my card. So any patient can ring me on my cell phone, and I quite often get a lot. So I'm going to tell you about 2 phone calls I got this week. So one lady rang me a couple of days ago, and she said to me, Anne, my heart was beating really fast last night. I said, was it? And I said, and did you ring an ambulance? No. I thought I'd just wait till this morning. I said, okay. And I said, how are you feeling now? She said, well, I've got a pulse oximeter and I've just put it on my finger. And she said, my pulse rate is 29. I said, right. You need to ring 111 now, and I will tell accident emergency that you're on your way to hospital. So just ring up. I'll ring back and make sure that you've rung the ambulance in a minute. So as she was in the ambulance, she actually was in VT, just small, not in VT completely, but she had some VT. And so she came in, and she's still in. The other patient that rang me this week rang me and said, Anne, I'm really quite short of breath. I said, oh, just walking? No, just all the time. I said, oh, how are your legs? Full of fluid, Anne. I said, okay, how long have they been like this? Oh, since last Friday. Oh, have you been to the GP? No. I said, well, I think we better go now. Put down on the phone, ring the GP, and we'll see. So went to the GP put them on furosemide, and the patient's now feeling better, and we got an X-ray done because I spoke to the surgeon. But these patients don't need me, they need medical assistance. So if they've got a big problem, they should be ringing an ambulance. If it's a smaller problem, they should be seeking medical assistance and getting to the GP. But quite often, they don't know what to do and they're nervous. I've looked after surgeons, GPs, nurses, and, they have been just as worried. I had a doctor in the hospital who had heart surgery who rang me up, and he doesn't mind me telling you. And he rings me up and he says to me, Anne, I said, hi, how are you? My heart rate is going 160 beats per minute. I said, really? And what are you doing at home? Oh, what should you'll be ringing an ambulance like anyone else and popping into hospital because you need to come in. So he came in, he was in for a couple of nights and then went home again. So it is scary for everybody. You know, it doesn't matter if you're medical trained people have probably needed my support more because they're aware of things. So just to be aware. Probably one of the biggest things I've looked after, and I suppose it's experience that I picked this up, was a lady who was in the country. She was a young lady. She had had valve surgery. And she rang me up. She'd been doing really well, walking really well, but rang me up and she said to me, Anne, I've got this real heavy pressure in my chest. I said, have you? I want you to come into A&E. And they echoed her heart and she was having a tamponade. So that meant that she had fluid around the heart, which could be a very serious condition. So she was lucky that they drained the fluid. But the problem, what I'm trying to say, in heart surgery, it's really hard to know what's a small problem or a big problem. And the research shows that. So there is science that I'll teach you along the way, how to, be aware and watch for them. So you'll see on my next slide, as I said, we ring them day 1, day 2 after they go home. Then we ring them 10 to 14 days, and that's when I ask them all these questions that we formalise from the problems that patients get. Then at 4 weeks, we either get them into clinic to be seen by our registrar. We've done an ECG and an X-ray at that stage. If there's no absolute issues as well, we'll manage them through a virtual clinic where the surgeon sees their X-ray, ECG. We go over if they're walking, their pain, their wounds. If everything's absolutely fine, we're not bringing them into hospital now. And it's such a move. A lot of centres now aren't bringing people in unnecessarily. So as I said, the district nurses and Healthcare NZ, we work very closely with them and other centres like Timaru, Ashburton and Bulla and Greymouth. I've got some beautiful supportive cardiac rehab nurses and nurse specialists there that we work with too. And of course, all of them get to go to their GP. With the GPs and the district nurses, our registrars, doctors are on call 24 hours a day. So quite often if they've got a medical problem and they're unsure, they ring our registrars. And of course, we've got surgeons on call every day. So that's what is so you understand what's available in the cardiothoracic ward. The biggest thing I know, if patients don't mobilise, they will develop complications. And quite often they go home and they're told to do less. And that is really sad because that's the way they form complications. So if you want a take-home message from me, if patients don't get up, moving, walking, remember before they've gone home, they've been managed to do 2 flights of stairs. They can shower themselves, dress themselves, do everything themselves. So why is someone showering them? Why is someone holding on to them when they're walking? So I'm going to tell you a funny story, and it's about one of my relatives. My auntie's boyfriend had heart surgery and he did very well. I wasn't really involved with his care, as you can imagine, but he was walking independently. He could do 2 flights of stairs. He was doing very well before he left. And she rang me one day just casually and she said, oh, he's doing so well. We went for a walk today and I was holding on to him and I gave him a stick. And I just said, you what? I said, do you want a boyfriend that you have to hold on to for the rest of your life? And she goes, no. I said, well, let him go. So I said he was walking independently. So it's really important because some of these patients don't get back to how they were before surgery. They lose their confidence. They've got to get back into life. They're not sick. They're recovering after an operation. Totally different way of thinking. So what I did, because I care for patients, I've done a form which they fill in when they go home. And I've been studying these forms. So what I've done is they have to fill these in from discharge. So if you're the district nurse looking after the patient, you can pull this out. So what they're doing is they're weighing themselves every second day. If they've got fluid in their legs, it's around their heart and their lungs. So I've just made it quite quirky. What are your goals for today? Are you independent with your medications? Are you shout and ready for action? How many times did you go street strolling and how long did you walk for? And so quite often I see patients can't do their meds without someone reminding them or helping them with it. And it's not like they can't do their pills, they're forgetful. So to be really honest, sometimes their wives are helping them with them. Are you shout and ready for action? Shout gets their lungs expanded, putting clothes on makes them feel normal. How many times did you go street strolling? When they go home from heart surgery, most can walk, say, 2 or 3 5-minute walks. And then they build it up. So at day 10, they could usually do 30 to 40 minutes without stopping. But because they're anemic after heart surgery, they have to build it up. If you send someone out for a 20-minute walk on their first day home, they would probably not be able to get back. And I've had that before. I've had someone wave down a car, so we don't want that. And they're weighing themselves. If their weight's up 1 or 2 kilos, they've got fluid. So that has to be addressed. And also you'll see extra activities, and I'll see things like I fed the cat, I was in the garage tinkering around, I went to a coffee shop. So it's just trying to get them in, trying to, get it back into normal life. Now, we had a professional rugby player. He's had valve surgery 3 times, and he filled out his form. He could do 90 minutes, of course, day 2 after home. And he said to me, I said, what did you do day 11? He said, well, the form only goes to day 10, so I didn't do anything because I knew you wouldn't be watching. But what I'm just saying to you, it's so important. So the idea of the form is to getting them back into life. And it was actually an idea from the district nurses because they were saying they were having trouble, trying to get people up and moving. So we did it as a tool to sort of help them. And, in the future we'll probably be having Fitbits or, other, devices so we can, help patients. And I know that's happening in other countries. So this is a patient's one that he's filled in. So you can see that he was independent with his medications. His shower was being fixed. So he had a wash at the bed. How many times did you go street strolling? He said 2 for 10 minutes. He visited the GP. You can see his weight. He did the dishes, so good for him. And this is an example of another patient. So his cat, Henry, ate the form, so he couldn't fill that in. But basically, he tells me he was bundled out and sent home. He was so exhausted and tired. The result was I slept for 4 days. And this is what you don't want. So the first days on my sheet, he actually did absolutely nothing. Just got up to the bathroom, and to be honest, he developed complications. So this is what you see. And why they do that is they've lost blood when they had their heart surgery. So they're anemic. So, of course, you want to lift the duvet up over your head and wake up when you feel better. And a lady said to me the other day, Anne, I'm going to get moving when I get energy. Well, it doesn't work that way. You get more energy from walking and moving. So this is what we see quite a bit. So that's him saying I was bundled out and sent home. I was exhausted. So he slept for 4 days. So do you honestly think that patients can go home alone after heart surgery? Well, I've asked them. So I asked 50 patients, could you go home alone after heart surgery? And I've actually asked more than that. So what the question is, could you go home alone after heart surgery with the district nurse coming in twice a day? So what the patients say is definitely no. And a few said yes. One of them said he didn't like his sister who was looking after him, so he'd far prefer to be home alone than be with his sister. So also, did patients develop issues following discharges, look at their yeses. So a lot say no, but a lot of them say yes. And the reasons for not coping at home is emotional and physical. Quite often the patients have lost confidence. If you see me looking, I've got this little fly thing that's coming to try to land on my nose. So quite often patients, it's emotional. They just need that support. Come on, let's go walking outside. I can't imagine them ever cooking a meal or thinking about what to cook for tea. But it's quite often emotional, but physical issues as well. And quite often they're frightened. And this is the type of issues that we see following surgery. So I've got some here: chest infections, constipation, fluid overload, heart rhythm problems, pain, pleural effusions, fluid in their lungs, short of breath, urinary issues, wound issues, and others. And this is why I did the booklet based on all of this, and that's what I did my Masters in. And now I'm going to take you through all the issues, well, a lot of them that I see after heart surgery. So the first one we're going to talk about is pain. So they really need adequate pain relief. And if they haven't, they need to see their GP or see the chemist or, really look at that. They should be able to cough, sneeze, and laugh without it hurting. If 5 was the worst pain they could ever have, they should be about 1. And men in my study were worse than women at stopping their pain relief too early. So it's really important, if they can, to take regular paracetamol, some in the morning, some at lunchtime, some at dinner time before they go to bed. So a man said to me the other day when I rang him, "How's your pain?" "I haven't got pain, Anne." I said, "Oh, that's good. This is 10 days after surgery. That's good." And next question is, "How's sleeping?" "Oh, I just get a bit sore." I said, "Well, that's pain. Take your pain relief." So this is what I hear. Now, angina is not normal after bypass surgery. So if someone's getting angina symptoms, don't tell them to take spray. They need help. There's something going on. They've had bypass surgery. They shouldn't be getting angina. Or if they are, they really need to see a cardiologist. And, we had one man who got angina after surgery, and one of his grafts was in spasm. So, he was put on medication and he came right. So just to be aware of that. Pain mainly comes from the bypass surgery leg discomfort. Patients tell me the leg nips and pinches. So just to be aware of that. And quite often it's numbness as well. So we have numbness in the shoulders, in the back and the arms, and numbness in the front where they took the mammary artery for the bypass surgery. So quite often there's numbness. Patients' mood. So they tell me their mood will go up and down. So that's what they say, moods go up and down. Quite often they get a bit down. Sometimes there's family fallout. Sometimes they're grumpy, frustrated, and that is normal. And sometimes they go home and they wonder why it happened to them, why this happened to me. So quite often we do the physical journey in hospital, but when they go home, that's when they think, this is so unfair, this happened to me. Especially for men, you've got to understand a lot of these people have not got money. They have heart surgery, so they can't go back to their jobs, especially if they're builders or they've got a heavy job. 3 months they won't be able to swing a hammer for. So I've had patients not going to the GP and fill their prescriptions because they've got no money to. So this is really important to know. They don't get ACC. So it's really, really quite a challenging time. I saw one man not even being able to get his Warfarin because he didn't have any money coming in. So it's something to really check out and know. And we observe for depression. We've got a clinical psychologist attached to Cardiothoracic, and I quite often refer to her to, support patients. And GPs are great. Quite often they've got counselling associated with their practice, so really important to know. And I have to warn the relatives that they can be really tearful and grumpy, so just to be aware of that. quite often, the family are the ones that end up getting grumpy or mad with them. Or one man, I always remember, he had a painter painting at his house, and he swore at the painter because he was being too noisy and he's trying to recover after his heart surgery. Then he rang me up crying, telling me that he abused the painter. Could I ring the painter and apologise because he felt awful? So I did, said to the painter, look, he's really sorry. Painter said, it's all right, I'll go back then, So these are just things, they can't handle it. I had a patient whose wife didn't come to my education session. She said she was getting her hair done. Her poor husband had his education, went home the next day. The wife worried all weekend. She was ringing the ward about things she was worried about. Son came to be at home to look after dad, but had his friends around all the time. Daughter came home. She was buying a house. So the house was, really noisy, and the poor man's trying to recover after surgery. So there was big sort of family fallouts, people not understanding, to be really mindful of someone in their process. And quite often for the relatives, they go through just as much, if not more. They've thought that their relative might die. So they've had all this stress, especially longer stays in the intensive care. Are they going to make it? So just to be aware of that as well. So with wound healing, it takes 3 months for the sternal wound to heal. So remember, they've been cut down the middle, down their sternum. They've got 3 or 4 wires keeping that chest together. 4 to 6 weeks it's getting strong, but it takes 3 months for that to completely heal. So we don't really have too many problems with the sternal wound. Sometimes I'm booking people back in that need rewiring. Quite often the reason that they need rewiring is they've coughed really hard and ripped one of their wires, or they've done something like one man was out surfing 2 weeks after surgery, got knocked off a surfboard, and I had to arrange for a surgery again for them to rewire his chest. So our dressings stay on 10 days and then they come off. They're all dissolvable stitches, so none to come out, only the ones where the drains are, and come out sort of 5 days afterwards. But if you take the dressings off, they're all dissolvable stitches, so that's incredible. Occasionally a stitch will come up to the skin level and then it's not dissolvable, so we just cut it off at skin level. And a patient saw me the other day and he had a wee scab, and when I lifted with my forceps, I could see that the stitch had come up to the level. The leg wounds sometimes cause the problems. But if you see a leg wound looking infected, deal with it very quickly so it doesn't break down, because we've done a lot of study on patients who have big leg wounds. They can't work, they can't travel. It really is very stressful for them. So it's best to act on something very quickly rather than leave something to get infected and end up with a vacuum. Is not what we want. And as I said, if they've got fluid in the legs, they've got it in the heart and the lungs. So if someone's put on 1 kilo, 2 kilos, so the other day I had someone, district nurses were going out and everything, but when the patient rang me, they put on 1.5 kilos and they were more short of breath. So they've got fluid. So I got that patient seen pretty quickly. The GP was great, put them on fruseminins, keeping an eye on them, and I'm x-raying them next week. So, we have to, if we can act quickly, otherwise, that patient will be back in with a pleurofusion needing a drain in. And, sometimes we're draining 1 litre of fluid from the lungs or more. And it's, having a drain is a very uncomfortable procedure. You wouldn't want them. And I just put this in. One of my patients got the top of his sternal wound sunburnt. It's the worst thing you could do. Imagine burning the soft tissue here. So just be aware. I don't think we have to worry too much at the moment, but just so you know. We tell patients to shower. You're washing the bugs down the plug hole. You don't want to be bathing in it or sparring in it or in the swimming pool. So just to be aware of that when their wound is still, not healed completely. sensitivity and scarring. If they develop scarring, we can do something about it, like keloid scarring. We've got an occupational therapist that can put a dressing on to flatten them down, or sometimes we send them to plastics. And sensitivity, some, a top even rubbing on their wound, and some women are very, very embarrassed about the lump up the top of the wound, which flattens down in about 3 months, but they can feel very vulnerable about it. They can feel that their scar down the front is very ugly. When my girlfriend had heart surgery, she used to wear a necklace covering it up, and now you can't see it at all. But, they're very, very vulnerable. So just to be aware of that. Land and transport regulations is 4 weeks. Some insurance companies want them to wait 6 weeks before they drive a car. To drive a car, you've got to have all your faculties about you. So, some people need longer. They're not ready. So to be aware of that. One lady, I always remember, she rang me up, and what had happened to her as she was driving 6 weeks after surgery in her own driveway, and her accelerator got stuck. And she didn't have the reaction quick enough, and her own car hit her own house. And the neighbour, who wasn't very pleasant at the time, rang the police. So she had the ambulance and the police, and she said she was absolutely so embarrassed, So she said, Anne, people should just, leave it a bit longer if they can. And, she did nothing wrong. She was insured, everything. But, she could lose her confidence from that. I've talked about heart rhythm changes. Patients say they feel palpitations, they feel funny beats. That is normal. But what's not normal is when the heart is beating really fast and they feel unwell, we tell them to ring an ambulance. And as I said, someone came in we've had people come in, 160 beats per minute. We've had the odd person in heart block. So just to be aware of this. Sometimes with a mechanical valve, people are hearing their valve. And it bothers them. Usually 6 months after, they don't hear it as much, but after heart surgery, they're very sensitive and they hear that mechanical valve. So quite often, it is quite an adjustment, especially for their partners too, if they're in bed hearing the valve as well. So just to be aware of that. So they know that before heart surgery, I show them the valve so they can play with it. Blood pressure. Some people don't take their blood pressure with them when they stand up. So sometimes their blood pressure is low after heart surgery. We're starting them on small amounts of beta blockers or ACEs. Sometimes that needs increasing about 3 weeks. And, be aware of their weight and their frusemide. We've had patients whose diuretics were meant to be reviewed a week after heart surgery, still on them a month later and falling over. So it's really important that they're looked at and titrated in the early times. And as I said, usually 2 to 3 weeks, their blood pressure is increasing. So sometimes they need their heart medication increased. And they all see a cardiologist about 6 to 7 to 8 weeks after heart surgery, depending. So quite often the cardiologist at that stage is looking at their medications, but we are also at 4 weeks. And if you're a district nurse coming to these patients, get their discharge letter, make sure they're knowing what they're taking, that they know when their medications are meant to stop, that they know what medications they're on. Remember, it's been a shock in the hospital, so quite often the information they've been given, they've forgotten. So just to be aware that they will need reinforcement with that. Sleeping. This is terrible for patients. They don't sleep after heart surgery. Quite often they have nightmares, vivid dreams. A man said to me the other day, and every person I saw, 100 of them. There wasn't just one. If you came along, I saw 100 of you. I said, you poor thing. Another time, sometimes one man said everyone was chocolate and everyone looked like they were chocolate. It was around Easter, but these are funny things. Another man said to me the other day, the curtains, and take them down. They're out to get me. And in the hospital, the sort of swirly curtains that he absolutely didn't like. Occasionally we have people getting delirium after heart surgery. So one patient thought that we're all out to get rid of her. We were poisoning her food. To her, it was very, very, very real. The only person she really trusted was me and the surgeon, because we didn't have a uniform on, and everyone else was from somewhere else. And it was very, very real for her. So when patients go home, they talk about nightmares, vivid dreams, just to be aware of that. Some patients require night sedation. You've got to remember, if people are only showering themselves and going for a 5-10 minute walk, that's not a lot to do. So most patients need to sleep in the day after heart surgery, so they put themselves to bed between 1 and 3. So that's what they tend to do. We don't sort of ring in that time. But also, the more they get back into the life, the tighter they are. And then they, sleep better at night. But quite often patients say to me they sleep for a couple of hours, then they need to go to the toilet, then they get back into bed, then they're sore. So this is what can happen. So it can be really tough for them. And, relatives are worried about them getting up all night. Then you've got two sleep-deprived people in the house, and then things are getting a bit tense in the house. So sometimes relatives go in another, room. And as I said, someone really needs someone with them for about 7 to 10 days after surgery, for that first week, because if something's going to happen, it will happen usually in the first sort of 7 to 14 days. So we talked about them having a rest in the day in the home environment. In hospital, our beds go up and down. Our air conditioning is, on all the time. Quite often when patients go home, they're very, very uncomfortable. They need more pillows. They're asking, can they sleep in their side? Yes, they can when they're comfortable. But just to be aware, it's quite an adjustment. Quite often I get tears from people ringing me up in that first week when they get home. Visual disturbances, dots in front of their eyes or flutters are quite normal after surgery, and we tell them not to change their glasses within 3 months. If visual disturbance continue, they need to see a doctor about it. They need to probably see an eye doctor, so just to be aware of that. So one man changed his glasses, didn't, even though we told him he forgot and they were useless. I had to help him to try to change the lenses with the optometrist, so just to be aware of that. This is the biggest complication after surgery is pleural effusions. How patients will know they'll be short of breath doing nothing. So if they're short of breath doing nothing, it's a sign we need to do something about it. I'm going to tell you a wee story. So one man, I rang him up. It was on a Tuesday. I rang him up on a Friday and I said to him, he come to the phone, "Hello, Anne. How are you?" I said, "How long have you been like that for?" Since Tuesday. I said, "Oh dear, put your wife on the phone, please." His wife comes to the phone. "Why haven't you taken him to the doctor?" "Because he won't go, Anne." And basically, his GP was great, rang his GP. He went to the GP and he listened to his lungs. Of course, he had fluid in the left side of his lungs. Put him on freezer. My GP rang me back to x-ray him on the Tuesday, which I did. Fluid was gone. GP told him to get walking and moving, which I would have done too, and we saved the patient a readmission. Chest infections happen occasionally, people coughing up muck in their chest, just to be aware of that. Need antibiotics for that, and weight gain we've talked about. Exercising, we must get people walking and moving, and it's not just, these are people that sometimes have to make health decisions. The plaque will build up in the bypasses again, so quite often, this is why we want them going to cardiac rehab classes after. This is why we want them to look at what things they can change. Diabetes, which is uncontrolled, they need support with that and get into activities of daily living and any complications to be looked at. Our patients are anemic after surgery, and we know. So we didn't give them a blood transfusion because we didn't want them to have one. So quite often they'll go to be told by people that they should have had a blood transfusion. We know, and we don't do it because it's contraindicated unless someone's hemoglobin is really low. Some people put them on iron tablets. What do iron tablets do? Constipate people. And one of my patients said, "Oh, it was worse having iron tablets than it was being anemic." So just be aware, if they're put on iron tablets, they must have something for their bowels. Quite often patients say about taste disturbances. They've had a tube in their mouth. Everything tastes awful. Tea tastes awful. Coffee, hospital food, this is quite a normal thing that they say. So sometimes they're eating things, with a bit more taste, having a bit of ginger ale, or one lady just wanted custard. Constipation, it's the worst thing you can do after surgery. So just to be aware of that. They should be telling the district nurse, telling the GP, going to the chemist, getting something for it. So just to be aware of that. Really important with valve surgery, we're looking for endocarditis. Anyone with a temperature, be worried. They could have an infection in their valve. How are we going to know is that it presents sometimes like flu-like symptoms. Everyone is told, that if they have to be careful with infection for the rest of their life. So just to be aware of, dental treatment, they usually on antibiotics before they have any of that. Any other, surgeries they have to have. So in my experience, every year we'd have 2 or 3 heart surgery patients that have had valves before coming back with endocarditis that can be fatal if it's not acted on. They shouldn't be put on antibiotics until we know what bug it is. So just be aware if someone's getting a temp after valve surgery, take it seriously. INR range, so if they've got mechanical valves, they're on INR, so aortic valves 2 to 3, and mitral valves 2.5 to 3.5. So lots of patients get a CALDWELL machine. A hemostasis unit in Christchurch trains them up how to use the CALDWELL machine with their GPs, and they're writing their INRs in their book and they're knowing. So one of our questions when we rang, what is your INR? How much warfarin are you taking? We had a patient come from Auckland once who stopped her warfarin with a mechanical valve. She came in very sick. We did an echo and it showed a big blood clot in the mechanical valve, and she had to have heart surgery again. And I've got the photos. It's such a huge clot, so it's really important. They are really serious about maintaining their levels. And quite often when they go home, their warfarin levels are up and down, so just to be aware about that. And medications, patients get discharge letters, they get medication cards telling them what to take when. So just to be aware, some patients stop their medications because they decide they don't need them. So just to be aware that you're checking on that. As I said, district nurses are coming into our patients. This is really important. It's a big adjustment from hospital to home, and our district nurses are really valued. GPs are great. Patients on warfarin are going the next day or in that week. Quite often they're seeing them a couple of times, 2 or 3 times. Some patients can't afford this, so just to be aware of this. Taking their medications, not stopping them, as I said about the warfarin. So just to be aware. To explain, and they need further education in the community. Referral to cardiac rehab classes. This is really, really important that they get to the cardiac rehab classes. In Christchurch, they do some in the evenings as well for patients in the day. Patients love it, and there's also some community groups. So after they've been to cardiac rehab, they have some community exercise classes as well. That they're normal with their activities, daily living. We want them to have a better life. One man sold his yacht straight after surgery, and then when he recovered, wanted it back. It was too late, so it's important they get into life. One lady who was my mother's friend who had heart surgery never went back to any of her activities that she did. And mentally, she just couldn't cope with it. Physically, she was far better than she was before the operation. And involve relatives in all the education. And this is just emotional findings, and I'm just about finished to open up for some questions. But several articles in my experience say cardiac surgery is the most very stressful time for patients and their relatives. And high stress and anxiety continues during the transition time from hospital and approximately 2 weeks after they go home. So when I see them at 4 weeks, they're usually dangerous, but certainly not in the first week when they get home. And spouses of the patients undergoing heart surgery indicate the most they felt really unprepared and anxious related to discharge, and despite all the education. So just to be aware of that, they're very vulnerable. And one study indicated that only one spouse in 5 felt prepared for the patient's discharge, and I really see that as well. And that's just to make you laugh. So thank you very much. So I'm just going to stop sharing now.
That's great, Anne. And you wanted to show people a bit of...
Yeah, so what I thought I'd show you, this is a mechanical valve. You can hear it a little bit. So you can see why they need to be on warfarin. So the surgeon actually measures the size of the valve that they're going to put in. And this is a tissue valve. This is just a model. So you can see what a tissue valve looks like. So the tissue valve, they don't need warfarin, but it's like a leather pair of shoes and it can wear out. So they say like 15 years, 10 years, just depending.
Quite big, aren't they?
They come in a couple of sizes too. Yeah.
Well, thank you, Anne. That's been really fascinating and really great to see that there's somebody caring for patients and their families throughout the journey. It's I can quite imagine why they would phone you first before phoning an ambulance, because they've obviously got a relationship with you.
Yeah, that's right, they do.
So we've got a few questions. So first of all, your patient information booklet, somebody's hoping that it's available online to be printed off.
Yes, definitely. I can send them to them. Okay,
how will you... what we need to do is give people your email address then, if that's
no problem.
I'll type it in the chat if you'll just read it out to me. Hold on. What's your email address?
Is Anne with an E.
Yeah.
.CALDWELL, CALDWELL.
Yeah.
At cdhb.health.nz. Hello, greymouth nurses.
Okay, so it would have taken me a while to find that on my system. So there we go. It's on the chat. So anybody who wants to contact you, you can help them with that. And do you use a screening tool or outcome measure for depression? And if so, which one do you use?
What we do is we don't so much right at the end. Anyone who is depressed needs to see their GP and needs to be monitored more. If we're finding it in hospital, it is, we are getting it seen to. But the hardest thing is they're very, very anxious. And sometimes that's what comes later. Because if you get told you're going to have heart surgery next week, you're really, really anxious and stressed. So sometimes the depression comes in later. So we get a clinical psychologist. Sometimes the surgeons will start someone on, some antidepressants. But quite often that's something that's picked up in the community, or I'll hear about it later. So we're not using a screening. We have done a screening before people had heart surgery, and what was picked up, it was more anxiety than depression. Thank you, Linda.
Good. And is there cardiac rehab provision outside of Christchurch?
Yes, there is. So we've got the lovely nurses in Greymouth. We've got cardiac rehab in Bulla. We've got cardiac rehab in Ashburton. We've got cardiac rehab in Amberley. So on the Heart Foundation website, we've got it all over New Zealand. And, it's brilliant. Patients really, speak very highly of the cardiac rehab.
So that's
sorry, Kathy.
So that's available on the Heart Foundation website.
You can see there's a directory and it's got all the centres, like there's some in Oamaru, some in Dunedin. So, there's
North Island as well as South Island. Yeah,
definitely North Island. So there's a directory there with all of them.
Good. And do you know what pre- and post-op education patients receive who choose to have their surgery done privately?
So at St George's in Christchurch, patients have education before surgery and after surgery as well. So we sort of do similar education, and So that's in Christchurch. And I know other centres. I've just done a talk at a heart surgery conference, and a lot of centres are doing education. Sometimes it's the cardiac rehab nurse from cardiology does the education there, but certainly private hospitals in Christchurch do education before and after.
Good. Now, there's something coming on the chat. For the patients who can't access a cardiac rehab class, how are they supported?
So quite often for them, there's things like through their GP, they can access, there's online things. What's that other one? I just can't remember offhand. But there is community things, or some people go to gyms. So sometimes I've worked with personal trainers with patients going back to the gyms. Some people want to do swimming. Some people want to do walking. So it's really what someone finds they like. It's no point them taking on something they don't. So I've had 2 young guys who, did a bit of the cardiac rehab but branched out to personal trainers as well. So I'm just trying to think. Someone online might know there's a government department that people can access personal training from centres that haven't got anything around. Yeah, okay. Can't remember the name. Yeah, green prescription. Thank you, Jen. Thank you, Hannah.
There you go. And somebody's asking, why are blood transfusions contraindicated in cardiac surgery patients?
Good. So there's lots and lots of research on it. If someone's symptomatic, of course, they will give a blood transfusion. But if they're not symptomatic, you're giving thicker blood to a patient that you want thinner blood. So basically that's a very easy way of explaining it. But a lot of the research says it's not helpful. So there's been study after study on that. But if someone is symptomatic, feeling unwell, the doctors will give them a blood transfusion. So they do sign saying that they can have a, that they're okay about having a blood transfusion, although we do get Jehovah's Witness patients who do not want blood products at all.
Mm. Right. Well, that's the end of the questions. We just had some more in the chat. I'll just check. Mostly people are just saying thank you for an amazing
I'm really grateful.
But there might be another question in there. No, there's nothing else coming through. So thank you so much, Anne.
Thank you, everyone.
Incredibly informative, and I can see how much it's been appreciated.
Great.
Lovely. And thank you, everybody, for joining us today. Please don't forget to fill in that evaluation form on your way out. All right. I'll close the meeting. Bye, everybody.
Thanks. Bye.